run something called Digital Health and Care Alliance, and we've got about 880 members who are mainly SME digital health developers. We were set up by the UK government in 2013. Our mission is to help our members to prosper by selling to the NHS and to other health organisations. And I was asked to take a positive approach, talk about digital health as a patient enabler. I've been sort of listening with a successive amount of dread as various of the things I was going to say have been said by Lars and Cecilia, but I'll try and make enough points to make it worth your while to listen to me just now. So I want to start off by saying what digital health isn't, because there are an awful lot of misunderstandings. I was talking to my sister the other day, saying I was going to give a presentation on digital health, and she said, "Oh, I don't like digital health," because she said that's what killed Uncle Donald. And actually what killed Uncle Donald was the fact that Uncle Donald had a very rare condition, and the rare condition that he had during COVID was incorrectly diagnosed by a doctor over the telephone. And somehow that was, the use of a telephone was therefore digital health. It was all the fault of digital health, and there was no other cause in my sister's mind. Something that my local doctor has said before is he doesn't like it because it gives him too much information. But of course, there are ways of dealing with that. When we ran the whole system demonstrator trial in the London Borough of Newham, and that's about 15 years ago now, actually, one of the things it exposed was that there was lots of unmet need in Newham, and actually that to me is one of the pluses about digital health, and that's that you see things that you couldn't see before. And it exposed that unmet need, but that's not the fault of digital health. It's one of the benefits of it, because we were able to meet those needs as a consequence. When we were in Newham, we also had problems too with people tinkering, particularly with telecare equipment, because they thought that that they would be unemployed as a result of the use of technology. And so they took scissors, for example, to bed sensors in care homes to make sure that they wouldn't work. It's also said to be expensive, which of course it isn't. It's considered to be a quick fix, and I think most of what I'm going to talk about today is trying to make out why it isn't a quick fix. And some people consider it to be a direct replacement for medicines, which very much it isn't. So looking at what medicines are, they're established. They tend to be a single intervention in that you take the medicine and then it has its effect. It's mainly a biochemical impact. If there's any data record, it's typically done manually, not always, but typically. It's genetically variable. Some genetic makeups work better with some drugs than others. There are adherence issues. 50% or so of people apparently don't take their medications as instructed. It's a slow development process, and randomized control trials were designed to evaluate it. So along comes digital, and digital is very different. Digital is multiple interventions, and I'll go into that in much more detail in a moment. The technology is just an enabler, to use Cecilia's term. It doesn't generate the benefits itself. There are multiple customers involved. It generates data essentially automatically. You can test specifics if you want to with it. There are network effects. So if twice as many people are connected, typically you get more than twice the benefit. It's not genetically sensitive in the way that medicines are. And one of the great benefits too is that there should be no adherence issues, because you know if the technology is being used. And if it's not being used, you can have a conversation, you can go back and you can discuss with the patient why it's not being used, and try to deal with it that way. There's a very rapid development process, and the end result of that is that it's very challenging sometimes to define what the benefits are. This, I think, I would like to think is my most important slide. There were profound moves in care delivery that have been very much accelerated by COVID-19. And there are three really significant changes that digital health does. Firstly, it enables you to move from episodic treatment, where you go and see your doctor measures something about you, or sends you off for measuring about something or other. He then, your doctor then gives you instructions as to what you should be doing, and gives you some medication, and you go away and you come back a few weeks later and it all starts all over again. Whereas with digital health, you can monitor someone continuously, and so you can treat them continuously. So it makes a huge change there. You move also from the aggregate to the individual. Just as a sort of tiny example of that, my wife's normal temperature is about 35.5 degrees centigrade. And so when her temperature is at 37, she's got a high temperature, and that's actually my normal temperature. And of course there are many other examples that when we were in Newham with COPD, it was quite common to have people with oxygen saturations of lower than 90%, and it became quite a challenge to actually warn the ambulance people not to immediately give them oxygen when they measured these low levels. And finally, the third significant change is the move from generic disease to particular. So, for example, once upon a time, if you had breast cancer, you had breast cancer. Now there are upwards of 14 different, very specifically different forms of breast cancer, and if you get the genetic makeup of that breast cancer perfect, and there is a drug that will or there is a treatment that will deal with it, your chances of full recovery are much greater than they were 15 years or so ago. And of course, this is changing the role of the primary care physician very significantly. And that in itself is a presentation that maybe we can't talk about today. There is, of course, a danger of accentuating health inequalities as a result of that. So what are all these interventions I was talking about? Well, the first one, and the main reason the main reason for digital health to be beneficial, is that it enables a change of care pathway, and that change of care pathway is typically where all the benefit comes from. But in order to do that, you need to invest in technology. You also need to train your staff typically to use the technology. You may need to recruit some staff. You may need to let some go. And very much what Lars was talking about earlier, patients may need some help in understanding their health literacy in order to get the greatest benefit from it. So buying technology makes great headlines, but it's actually helping people to use it that bring the benefits. And good management is what it's all about. What it also needs, obviously, is access to technology, and that includes a network, which I guess goes without saying. A minimum aptitude, something that I don't think should ever be underestimated is that good user-centered design makes an enormous difference to how easily people use digital health. And it's extremely noticeable. For example, I don't think I've come across anybody that struggles with using an Apple Watch to monitor their exercise and such like, whereas some of the other devices that certainly I used in the past were a real struggle. And I think something that that COVID-19 has in particularly exposed is that patients who book an appointment with their doctor just because they want an appointment do not get the best out of their GP, and instead, if they say, what do I need to do to manage my own health, and how do I need your help in and do I need your help in doing that, results in a completely different attitude from the doctor. And of course, the holy grail in all this is accepting that my health is my responsibility. So just to conclude my short presentation, there are many unhelpful myths about digital health technology. And those mainly arise, I reckon, from fear of change. It delivers patient outcomes very differently to medicine, which some people have a problem with. But outcomes will increasingly be transformative to almost everyone's benefit. And this move from a snapshot to continuous monitoring, from treating people as the same rather than treating them as individuals with individual readings, and likewise treating diseases as being generic, moving to specifically treating them will further transform those outcomes. But the greatest benefits, of course, will come to those who actually accept personal responsibility for their own health. However, the need for a minimum access to technology and the need, as both Celia and Lars made out, of good aptitude and good health literacy will mean that some people continue to need help. But I guess, you know, I've been doing digital health now for probably 15 years, and I think we're still learning. So that's the end of my presentation. Thanks very much.